is not wanting to be recorded. Okay, so I can see the people that don't want to be recorded. So, okay, I think they changed their mind. Okay, that's fine. So we're good. All right, so I think the call is definitely being recorded right now. So let us see how far we can run. I'll share my entire screen. Just 1 minute, please. I'll share my entire screen and we'll move on. Okay, so all right, so let's move on from where we stopped the last time. Now, this is the pressure volume loop. A lot of people struggle with the pressure volume loop quite a lot. Now, when you look at the pressure volume loop, the pressure volume loop is one of the easiest thing you can definitely do. That's one of the easiest thing you can definitely do, even though it looks a lot more tricky, but it is actually very, very easy. So we're definitely going to sit down and we're going to tie in this concept one after the other until everybody is fine. Now, there's a way we're going to look at this concept. We're going to look at it in a different dimension from um, the normal way you must have seen it in your FA. So let us look at it from a different light. Now, let us look at it in this direction. I'm going to draw the heart first. Then we can explore the various possibilities. We can definitely explore the various possibilities. So this is, let me change it. Now, this is the left atrium. This is the left ventricle. This is the aorta. This is the system we're going to be doing this one. Now, see what I want you to understand first before we start tying in the concepts. The pressure in the left atrium. So this is left atrium. Let's label this left atrium. Let's label this left ventricle. Now, the pressure in the left atrium is less than 12. While the pressure in the left ventricle is, let me say, 120 over, let's say, 10. Or maybe 120, 121 over 10. Now, the pressure in the aorta is 120 all over 8. Now, see what I want you to understand. Veins will return blood back to where? They will return blood back to the atrium. So the atrium is what receives blood from the vein, especially the pulmonary vein. Now, when this blood is in the left atrium, we want to empty that blood to the left ventricle. The blood is here now at the left atrium. It is the job of the atrium to empty that blood into the left ventricle. But now look at what I want you to observe. The left ventricle has a pressure of 120 over 10. meaning the pressure can rise up to 120 and it can fall as low as 10. Now, for fluid moves in pressure gradient. What do I mean by pressure gradient? Fluid will always move from region of higher pressure to region of lower pressure. So for this blood to move from the atrium to the ventricle, the pressure in the ventricle will have to fall below the pressure in the atrium. That is a rule. Now, look at what happened at the end of systole. Systole is ventricular contraction. This blood pressure that is above is what we call systolic blood pressure. Check it now. If you do blood pressure for your patient, most of you that work in a hospital, if you say his blood pressure is 120 over 80, it simply means that his systolic blood pressure is 120, his diastolic is 80. Now, that is the same thing, is also applicable to the concept we're dealing here. The 120 is the systolic ventricular pressure, while the 10 is the diastolic ventricular pressure. Now, what it simply means is that at the end of systole, the pressure in the ventricle is 120. 120 is far above 12. So what do you think will happen once your systole is over? The aortic valve will close. This is aortic valve. Once aortic valve closes, it means systole is over. Blood is no longer leaving. On the other hand, the mitral valve will fail to open because the mitral valve cannot open because the pressure in the ventricle at this point is far higher than the pressure in the atrium. So the mitral valve will refuse to open. Now, what will happen is that this pressure in the ventricle will start to fall. It will fall from 120 to, let me say, 110, 100. It will keep on falling till like 50, 40, 30, 20. It will now fall to 10. Once it hits 10, 10 is now less than 12. It simply means that the pressure in the ventricle has gone lower than the atrial pressure. That is when the mitral valve will open. Then blood will now move from the from the left atrium rather to the left ventricle. Now, when you look at your pressure volume curve, when you look at your pressure volume curve, this black one is the normal. Let me reproduce it again. Let me reproduce it small here. Let's make it a bit small so that we'll definitely know what we're talking about. So I'm trying to make it small. Now, see what I want you to understand. This is volume. Here is volume. This is pressure. Now, look at this point. This is the point where your aortic valve closed. That is this point. That is where systole ended. Look at the pressure. The pressure is like 120. At this point, the atrium cannot empty its blood. Now, this pressure will need to fall from this 120 to about 10. Let's say this is 10. If this pressure falls to about 10, at this point here, the pressure in the ventricle has gone below the pressure in the atrium. This is where the mitral valve opens. You can now see the volume will start to change. This was initially where the volume is, let's say 100 mils. You see that during this time of relaxation, where the pressure is falling from 120 to 10, the volume of blood in the ventricle still remained at 100 mils because all the valves are closed. Both the aortic and the mitral valve is closed. So the heart is relaxing, but there is no change in volume. That is what you can clearly see here. The volume remained 100, but the pressure moved from 120 to 10. That is the first thing. That is what is called isovolumetric relaxation. Iso means no change in volume, but there is change in pressure. Now, at this point here, let's say this is point A. This is where the mitral valve now opens. Now look at the volume. The volume now increase. At this point now, it simply means blood is entering the ventricle because the volume is increasing. At this point now, this is where the mitral valve closes. This is where your diastole ends. Let's say the blood in the heart now is about 100, 1000 rather. You started with 100. Let's say 900 extra came in. So what you have at the end of diastole is 1000. This is your end diastolic volume at this point. This is the end diastolic volume. We're going to draw it in a bigger board, but I wanted you to see both images. This is the end diastolic volume. Now, what you need to know is that at the end of diastole, the pressure you have in your ventricle is 10 because that is the diastolic pressure. So in this ventricle now, the pressure you have is only 10, and this ventricle has the responsibility of pumping this blood into the aorta. And the aorta has a pressure of 120/80. That is the least pressure in the aorta is definitely 80. Now, what that simply means is the ventricle will have to step up its pressure to at least 80 before the aortic valve will open. That is exactly the next thing we'll see. So under this condition, the mitral valve has shut close. The aortic valve is also refusing to open because the pressure in the ventricle is very low. So what will happen now is the pressure in the ventricle will start rising, but the volume will not change because the both valves are closed. Now this is what they call isovolumetric contraction. At this point, you can see that the pressure is rising, but the volume is still at 1000. It is when this pressure has risen and hit 80, that is when the aortic valve will open. Oh, the pressure has gotten to 80, aortic valve will open. So at this point here that I'm marking C, this is where the aortic valve is opening. Remember, B is where the mitral valve closed from what we're illustrating. So at this C now, the aortic valve has opened. So this particular ventricle will start emptying their blood out. Now look at this is, if you trace this to the horizontal, if you trace this now to the horizontal, this is 1000 mil, which is the end diastolic volume. But look at what is happening. The ventricle is emptying the blood, meaning the volume is reducing. At this point now, if you trace this point to the horizontal, is 100 mils, meaning it has taken out the blood that came back to the heart. So at this point, C, aortic valve opens, the volume starts changing because it is now moving towards 100. Now, when it gets to this point, D, your systole ends, your aortic valve closes, and the isovolumetric relaxation happens again. That is how it keeps happening. Now, this is all what they were trying to illustrate using the black line. The black curve in this diagram is normal. But if you understand that pressure differences in the heart that I illustrated, you can definitely make sense out of this diagram a whole lot. Now look at the thing I illustrated. At this point here, this is where the aortic valve closed. That is where systole end. The pressure in the heart is very high. It's about 100, 120. That is far higher than the atrial pressure. So the atria will not empty because the mitral valve cannot open. Now, this is where you have your isovolumetric relaxation, which is number 3. You can see that the pressure is falling, but the volume is the same until the ventricular pressure falls below the atrial pressure. The mitral valve opens. Now, when the mitral valve opens, you have blood running into the ventricle. Now, there are two ways the ventricle empties its blood. So let us quickly look at the way it empties its blood, then we'll come and tie the other concepts quickly. Now, this is the atrium. So the atrium is what we're talking about. There is two ways the atrium empties its blood. Let's say this atrium has blood here. No, let's use red. Let's say all of these things are blood. No, let's draw it a bit. Now, let's say this atrium has blood all over. All these things are blood. And now, this is the mitral valve. It's closed. So the mitral valve is preventing this blood from leaving. It is definitely caging it. The blood cannot leave. Now, once the mitral valve opens, if the mitral valve opens, we take this out. Automatically, what will happen is that gravity will move some of this blood, especially these ones, will rush via the force of gravity. They will definitely run into the ventricle. But now look at this other one that is left. This other one is definitely sustained by all these pockets here. Gravity will not pull these ones necessary. The ones gravity can pull, it has definitely pulled it. Now, this one we also need to go into the ventricles. How will they go into the ventricles? They can go into the ventricles by contracting the atria. If this atria contracts at this point, imagine you add a force at these 2 points. That force will definitely force this remaining one to definitely move into the ventricles. So the first time the mitral valve open, there's what we call the passive ventricular filling. That is that first movement. That is what you have in number 4. Look at this is where the mitral valve opens. So number 4 is the passive ventricular filling, the one that gravity does. When that one has finished, the next one is definitely where the atrium will now have to contract. Now, when the atrium has contracted, of course, all the blood will now definitely get into the ventricle. At that point in time, the mitral valve will shut close. That is what you have here, closure of the mitral valve. Now, at that point, the pressure in the heart is 10 because it is the diastolic pressure, the pressure in the ventricle. Now, the ventricle needs to pump this blood it has received into the aorta, like I explained. Pressure in the aorta is 120/80. And the pressure here, you can classically see it is very low, far lower than 80 or far lower than 120. So what will happen is that the heart will start contracting and only the pressure will be rising because the both valves are closed. That is the isovolumetric contraction, which is the number 1. By the time you get to 80, aortic valve opened. Automatically, you start emptying the blood until you get to this point, aortic valve closes. That is what this image is illustrating. Straight up. That's what it's illustrating. Simple. Now let us tie in more concept to this. Let's tie more concept to this. You need to learn how to play with this information. Now let us look at this. Let's look at this. Now let us tie in that's our normal graph first. Let's start with the normal one. And if they want to give you things to compare, they must start by giving you what is normal. They are not mad. They cannot give you abnormal when they've not told you what is normal. That is not possible. They must tell you this is normal. Then you can now start comparing with the abnormal. Now look at this. Let's assume this is our normal in black. Now let me expand this thing so that we can tie in a lot of things here. Let me expand this. I'm going to tie in a lot of concepts here. Now let's use this in black. This is your isovolumetric relaxation. This is when the feeling started. This is your end diastolic volume. This is isovolumetric contraction. Aortic valve opens at this point. The emptying started. It emptied and it got to this point. Aortic valve closes. Now I have to make it more circular so that it doesn't look like isovolumetric. So this should come on. So this is where the aortic valve closes around this point. This is the normal for you. Now let us bring something. Let us bring that green. Let's bring the green again. Let's assume this is another one. This is another of this curve. Similar curve. You just need to be smart. Well, now look at something. This is how this green now is. Now, if I'm to ask you what is the difference between this green and the black, understanding that here is the end systolic volume. Why would this be the end systolic volume? Because this is the volume of blood in the heart after systole. This is where systole ends when the aortic valve closes. That is where systole ends. So this is the end systolic volume. And this is where your mitral valve opens and the ventricle starts filling. This is where the mitral valve normally closes and the ventricle stop filling. So this is the end diastolic volume. This is for the blue, for the black rather, that is normal. Now, one of the things you can definitely pick at is this. Your green has a bigger end diastolic volume. Let's assume this place is 100. This end systolic volume. Let's assume the end diastolic volume is 1000. Obviously, the end diastolic volume for this green would have gone to like 1200. So it simply means the end diastolic volume of the green curve is bigger than that of the normal curve. What can drive this end diastolic volume to go this high? That can definitely be increased preload. If you remember, increased preload can definitely do that. Now, if you have that understanding, what you now need to also understand is that the stroke volume will go up. At this point in time, I know you're very smart. The question I want to ask you is, what is stroke volume? We settled it the last time that stroke volume is your end diastolic volume minus your end systolic volume. So look at the normal person. The normal curve now, which is the black curve, the end diastolic volume is 1000. If you minus if you minus 100, which is the end systolic volume, look at the formula for stroke volume. I need you to do this thing too so that you understand it. End diastolic volume minus end systolic volume. So let's do for the black curve. For the black curve, end diastolic volume is 1000, end systolic volume is 100. So the black curve will give you 900. Now let us do for the green curve. The end diastolic volume for the green curve is 1002, while the end systolic volume, this is end systolic volume, is definitely 100. If you do the mathematics, the difference is definitely 1001. So you can definitely see that the stroke volume will increase in the green line compared to that of the normal person because your preload to the heart increases. These are all the interpretation you can pick out from this graph. Now let us add some more things. Now let us assume we bring up another curve again. I like teaching with the board a whole lot. That is what I enjoy, using the board to teach a whole lot. I don't like reading the literature for you word for word. If it's reading the literature, you have the literature, you can read the literature on your own. So you just have to bear. We'll be doing more of the whiteboard teaching. Now look at this other curve. Look at this other curve. This is the brand curve. Now there's one thing I want you to understand. If you look at this brand curve and you look at it critically, the end diastolic volume is the same. But I can guarantee you that the systolic volume increases. I know a lot of people will ask me, how did you know? We're going to sort it out practically here. If you look at the end diastolic volume, the end diastolic volume for the black and the brown is the same thing, 1000. But look at the end systolic volume. The end systolic volume for the brown line decreases markedly. This should be around, let's say, this is 20. Instead of 100, this is 20. Now, let us do the mathematics. Look at this is what you have in the normal person, which is the black line. The stroke volume is 900. Now, in this brown line, the end diastolic volume is 1000. Why the end systolic volume is 20. 1000 minus 20 will give you 980, meaning stroke volume increase. Now, the question I will ask you is what can make your stroke volume to increase when your preload is unchanged or your end diastolic volume is unchanged? That is definitely when there is increase in contractility. So the brown line is definitely telling you that contractility has gone up. That is what is implied straight up. Now, this is the interpretation for all of this. There's one I needed to tie in. There's one I need to tie in. But I'll have to tie that one in using the next whiteboard because I drew this thing too high. So let me tie in the final one here, and then we can run and move on to something next. Let's tie in the final one. Now, we have to expand this so that it will make a lot of sense. Now, if that is expanded, so let's try to reproduce the black again. This is your N. This is isovolumetric relaxation. This is your diastolic filling, isovolumetric contraction. Aortic valve has open. You have aortic, you have emptying into the aorta. Aortic valve closes. Now, see what I want you to see. Let's look at this. Now, look at this. Now, I want you to think of something. This particular blue line, what do you think this is? Remember, this vertical is pressure, the horizontal is volume. What this thing simply means is that the pressure has gone up more than normal. Remember, your afterload is a function of pressure. Your afterload is when the pressure that the heart needs to overcome to pump out the blood increases. So you can classically see that in this blue curve, pressure has gone up. Now, when afterload goes up, what did we talk about that will happen to your stroke volume? Your stroke volume will definitely decrease. We can definitely see that here. Let us look at it practically. Let's assume again, this is your end diastolic volume normally. This is 1000 from what we settled in the last time. This is 1000 for end diastolic volume for the normal black curve. This is the end systolic volume for the normal black curve. We said is 100. Now, the end diastolic volume for both curves is the same at 1000, but look at the end systolic volume for the purple line. This is where it is. This is about, let's say, 300. This is 300. Now, let us do the mathematics practically. This is the normal black. This is the normal black line. So I'll use the black color. This is the normal black line. Now, you can see that if you look at the normal black line, end diastolic volume is 1000 minus your end systolic volume, which is 100. So you have 900 as your stroke volume. This is stroke volume. Now look at the stroke volume in the afterload. Now the end diastolic volume here is 1000. No, let's use the same color so that you appreciate it. End diastolic volume here is 1000, but the end systolic volume is 300. 1000 minus 300, this will definitely give you 700. So classically, you can see that the stroke volume has dropped because afterload went up. These were the things we discussed in our previous class. I have taken a lot of time to tie in this concept in such a way that everybody should understand everything that was said here. So I have tied in number 1 to number 5 in such a way you will understand. Now, when you listen with a stethoscope to a patient chest, what are you trying to hear? You're trying to listen to the heart sounds. There's a lot of things you're trying to hear, but one of the things is the heart sounds. You need to know how a normal heart sound before you can even know how the abnormal one would be. Now, the question I need to ask you is, what is producing this heart sound? What is producing this heart sound you normally hear with your stethoscope? What is producing it? What is responsible in causing it? Now, what you need to understand is this. You need to understand it and understand it well. Now, just imagine when you leave your room. Okay, just imagine you have a teenager, a very angry one in that matter, and she wants to go to party, and you tell her you can't go to party, and she angrily slammed the door. When she angrily slammed the door, what will happen? You will definitely hear a large sound. If she closed the door quietly, you may not hear the sound. But when she slams it, you will definitely hear a large sound. Now, when you talk about your heart sounds, your heart sound is caused by closing of the valve. When the heart valve closes, they produces that sound that is similar to when a door closes. So your S1 is heard when your mitral valve closes. This is where your mitral valve closes at the end of diastole. So the closing of the mitral and tricuspid valve definitely give you the S1. That is normal. Now, when you look at your S2 is when your aortic valve and your pulmonic valve is closing. This is the point where the aortic and pulmonic valve will close simultaneously, almost simultaneously. Same with mitral and tricuspid valve, they will close almost simultaneously. So this gives you your S2. Now, when you talk of your S3 and your S4, these are abnormal heart sounds. They are not normal. They are not normal at all. Now, what I want you to know is this. Let us go back to the whiteboard again. Remember, I told you something that there's two ways your atrium empties its blood. The first way the atrium empties its blood is that it empties the blood via the passive filling. Once the valve opens, of course, the blood will definitely run out. As simple as that. There's nothing you can do. As long as that valve opens, the blood definitely trickles out. It is wired that way. Now, the other thing you need to know is this, and this is what is also important. After that rapid filling, the next thing is that the atrium will have to contract. Once the atrium contracts, that will definitely help in pushing out the rest blood. Now, look at what causes S3 and S4. They are abnormal heart sound. I will tell you the scenario where they are normal. Let's assume this is your ventricle, your left ventricle. Let's assume above is your left atrium. Now, let's assume this patient has a condition that there is already excessive fluid in this ventricle. Let's assume there's already excessive fluid in this ventricle. For example, this patient has congestive heart failure, or this patient have aortic regurgitation, or a mitral regurg. You have fluid already in this ventricle, excess, because of the congestion or because of the regurgitation. Now, when this mitral valve opens, blood in this atrium is supposed to rapidly run into the ventricle, but the ventricle is not empty. Now, this blood that is running from the atrium to this ventricle will definitely cause a turbulence in this blood that is already in the ventricle. That turbulence is what you now hear as your S3. That is the reason why you see S3 in any condition that will already cause fluid accumulating in the left ventricles, mitral regurg, atrial regurgitation, heart failure. Now, when you also look at this, you can also see it in dilated cardiomyopathy. You can also see it there classically. Now, there are two conditions where you can hear your S3 and it is normal. Those two conditions are in a pregnant woman and in a young, skinny athlete. So if a young guy who is athletic and is skinny comes to me and I listen to his heart and I'm hearing an X-ray, I would not be in a hurry to start doing a lot of things. I'll have to chill first. If I hear it in a pregnant woman, I also need to take a chill pill because it can be normal in those two cases. Now look at what causes your S4. On the other hand, your S4 is caused by ventricular wall thickening. Any condition that causes the ventricular wall to become stiff. Let's assume this ventricular wall now is thickened. This is a thickened ventricular wall. Now remember that there are two ways of emptying. There are two ways of emptying your atrium. The first one is the passive phase. The second one is definitely the active phase, which is the contractile phase. Now, let's assume we have emptied the blood in this atrium via the passive phase. It is remaining these ones now that are hidden in the pocket, these ones that you need the atrial contraction to move out. Now, look at this guy's ventricle. This guy's ventricle is very stiff. Maybe he has chronic hypertension or he has aortic stenosis or acute myocardial infarction. Remember, I told you that any condition that causes increased wall stress will cause a compensatory cardiac remodeling by increasing wall thickness. I talked about it yesterday and I talked about it at length. Now look at what caused this problem. When this atria will contract via the atrial kick, this blood will definitely be launched in such a way that it will slam on the wall of this ventricle. It will slam on this stiff wall. As the atrium is contracting and pushing it out with force, that force will slam against the rigid wall of this ventricle. You will now hear the S4 sound. So think of any condition that causes increased ventricular pressure and cause ventricular remodeling. Hypertension is there, chronic. From that yesterday's conversation, you know why hypertension can do that. You can definitely see that too in aortic stenosis. You know why. You can also see that in a patient that has dilated cardiomyopathy. No, hypertrophic cardiomyopathy, sorry, hypertrophic, dilated should be S3. Now let us look at the pressure and time tracing. Now look at this particular tracing is different from the one you saw before, but it is still the same thing. You just need to understand the basics. If you understand the basics, every other thing becomes easy. You just need to get to that point where you can tie things together and avoid unnecessary cramming. Just be comfortable with tying in your content. That is what is important. Now, let's quickly tie them in again. Let's go to the whiteboard again. If you get this page completely, I think we've done a whole lot already because that's one of the most tricky page, and it is a very high yield cardiophysiology page. That is why I'm spending a lot of time on it. Now look at this other graph here. Look at this other graph. Let's use this black. This is pressure here. And let's assume let's say this is time. Now let's look at this. This went like this. This curve started from this low point. Let me raise it a bit because of something. So let's start from here. It started from this low point and it moved up And it got to this point, when it came down like this. Now, this red one moved like this. Now, this red line, okay, let me just add something more. This blue line is the atrial tracing. The pressure in the atrium is represented by the blue line. Now, the black line is the pressure in the ventricle. The red line is the pressure in the aorta. Now, see how this thing makes sense. Look at this point. The pressure is going up. Let's assume this point here, this should be a pressure of 120, for example. This is a pressure of, let's say, 80. Now, this is the point where your mitral valve closes. You have to be smart. It is after the mitral valve closes that you will have isovolumetric contraction. Go and look at the other image. You just have to be smart. So at this point, A is where your mitral valve closes. So you can see the pressure start rising. This is isovolumetric contraction until you get to this red line. This is the aortic pressure. This is where the aortic valve opens. At point B, this is opening of the aortic valve. This is where you have the blood now entering into the aorta. So there's emptying of blood up till this point here. C, this is where your aortic valve closes. Now, at this point is where you have your isovolumetric relaxation. You can see the pressure is falling. Up until this point, look at the black line falling slightly below the blue line, meaning the ventricular pressure is now lower than the atrial pressure. Your mitral valve opens at this point. That is just what that graph is trying to illustrate. It is almost similar to what you have on the other part, but it's just a reversal. You just need to understand the basic concept. If you understand the basic concept, you can trace it completely. So this is opening, this is closing of the mitral valve rather, so that isovolumetric contraction can happen. Aortic valve opens, the blood is emptied, aortic valve closes, isovolumetric relaxation happens. Look at the atrial pressure going above the ventricular pressure. Mitral valve opens, diastole starts. That is what you have there. Now, when you look at the next, the next is the one we call the atrial pressure tracing. A lot of people don't like the atrial pressure tracing, but I'm going to talk about the atrial pressure tracing. We're going to look at it, and then we'll definitely talk about it classically. So that is the next thing we're going to do now. We're going to look at the atrial pressure tracing. I'll try to explain certain concepts that is definitely associated with it. That is exactly what we're going to do. So let us quickly go in and definitely talk about them one after the other. So let me attempt to trace that and I will try to explain them. This is the A wave, followed by a C wave, which will definitely follow an X descent. An X descent will follow a V wave. The V wave will follow a Y descent. This is your A wave. This is your C wave. This is your X descent. This is definitely your V wave. This is your Y descent. This is the tracing. We're going to talk about this one after the other. We're definitely going to be talking about it one after the other until everybody definitely follows. Now, see what I want you to understand. Remember, we said something, and what we said early is that the atrium has two ways of emptying. The atrium can definitely empty by passive filling, or it can also empty by atrial contraction. Now, this A wave is caused by atrial contraction because you can see that the pressure in the atrium went up. So when the atrium contracts, of course, contraction increases pressure. Even in systole in the ventricle, it means ventricles is contracting, pressure is going up. So the A wave here simply signify atrial contraction, which is the same thing as atrial kick. That is what empties the blood that is remaining in those atrial pockets after the passive filling. That is what the A is. Now, by right, when that atria has emptied the remaining blood, the Tchaikovsky valve or the mitral valve is supposed to close. Isovolumetric contraction will start. That is what we settled. Now, let's assume this is the heart at this point. Let me illustrate it with this. Let's say at this point now is where you have the Tchaikovsky valve. This is the right atrial tracing. Let's say this is the Tchaikovsky valve. The Tchaikovsky valve has closed. After that atrial kick, you've emptied all the blood in the atria, so the valve has closed. Now, the aortic valve is also closed. Now, the pressure in the ventricle is very low. So the ventricle will need to step up its pressure to be able to push out its blood. That is where you have the isovolumetric contraction. Now, come to think about it. This particular ventricle is filled with blood. See, this ventricle is filled with blood, though, because this is happening at the end of diastole. It has received blood fully. And this ventricle now starts contracting against two closed valves. The two valves are closed, and this ventricle starts contracting. Just imagine pressure is added here. Pressure is added here. The valves are closed. What do you think will happen? Automatically, you will have the blood causing a bulge of this Tchaikovsky valve because of the pressure you applied in it. That blood definitely, since the two valves are closed and this valve is flexible, this blood will definitely cause the valve to bulge into the atrium. That is what is causing this C wave. The C wave is during that isovolumetric contraction where you have both valves closed. The pressure in the ventricle causes the Tchaikovsky valve to bulge into the right atrium. If it's the left side of the heart, the pressure in the left ventricle will cause the mitral valve to bulge into the left atrium. Think about this thing. Just think about the fact you have a balloon, you inflated a balloon, and you filled water inside of that balloon. You filled water in a balloon or this latest glove, you fill water in it, and you now press the middle. You will see that the water will definitely bulge from the sides. That is exactly what is happening here. So that is what is causing your C wave. Now, after this, automatically what will happen is blood will start leaving. After the isovolumetric contraction, of course, blood will start leaving the ventricles. When blood start leaving the ventricles, automatically the pressure will definitely be relieved from this Tchaikovsky valve. It will definitely come to normal, and the pressure in the atrium will definitely be falling because atrium and ventricle, they go in opposite way. If the atrium is relaxing, the ventricle will have to be contracting and vice versa. Two of them cannot be doing the same thing at the same time. That is why the body is so dynamic. Once the atrium is relaxing, ventricle is contracting. So this is when the ventricle is contracting, the blood is now leaving. So the pressure in the right atrium will definitely start to fall rapidly because the pressure needs to fall below the vein for you to have venous return coming back to the right atrium. So this X descent is when you have the pressure in the atrium falling after that isovolumetric contraction that causes this Tchaikovsky bulge. So the S descent now, the pressure is now falling. Now, when it falls to this point, it has fallen below the pressure in the veins. The veins can start returning their blood back to the heart. Now, when the vein starts returning the blood back to the right atrium, as the blood is coming in, pressure is building gradually. Volume and pressure are directly proportional. If I give you 10 liters of fluid to carry, and I give you 50 liters of fluid, you will find out that the 50 liter will cause more pressures on your hand than the 10 liter would. So as the atrium is filling, automatically pressure will be going up until this point. Once you've gotten to the peak of V, this is where your Tchaikovsky valve or the mitral valve will open. This Y now is that passive ventricular filling, that one that gravity does. At the end of Y, of course, you now have your atrial kick, which is A, and it will flow in that line. This is the atrial pressure tracing. If you understand it like this, you don't need to stress yourself too much. This is the best way for you to understand it so that you don't get to stress so much. Now, if this is understood, let us press on. Let us press on. Now, moving on, let us look at some conditions where you can have abnormalities in some of these tracing. If you have atrial fibrillation, you're not going to get the A wave at all. The A wave is always absent in patients with atrial fibrillation. Because in atrial fibrillation, the atrium cannot conduct the atrial kick. The atrial kick cannot happen. If the atrial kick cannot happen, you cannot have the A wave. Now, it's not possible. Now, on the other hand, in patient that has third-degree heart block, that is the AV dissociation, they have the cannonball A wave. Now, let me explain this. There's just a lot of information in this pathway to know. The challenge a lot of people have is that they don't get to meet the right people to definitely tell them the things that is important and how they need to know those things. There's just a lot of things embedded. If you get your concept from the perspective of understanding, it makes it a lot more easier. Because no matter how they decide to twerk that question, you have understanding. You can definitely pick it and say, no, these people are trying to whine me. This is where they are going to. You can pick out your answer and move. Now look at the concepts behind that canon A wave. Now, what you need to know is that the heart needs to be synchronous. That is what you need to understand. This is your atrium. This is your ventricle beneath it. Now, the atrium and the ventricle, they don't work the same time. They work in opposite way. For example, if the ventricle is contracting, the atrium must be relaxing. On the other hand, if the atrium is contracting, the ventricle must be relaxing. Both of us cannot be doing the same thing at the same time. So if your atrium is contracting, what we expect is that your ventricle would be relaxing so that this mitral valve will open. That is why the atrial contraction is even the last thing, because the mitral valve opens first and blood runs into the ventricle before even the atrial contraction happens. Now, in patients that have severe AV dissociation, the atrium and the ventricle, they beat differently. They are no longer synchronous. That is why it is AV dissociation. Now, they are no longer under synchronous control. What it simply means is that the ventricle can be contracting and the atrium contracting at the same time. Now, let's imagine that the ventricle is contracting. As long as the ventricle is contracting, this mitral valve will be closed. Now, let us imagine that the atrium wants to contract against this closed mitral valve. Just think about it. If the atrium attempts to contract against a closed mitral valve, the kind of pressure that will accumulate in that atrium will be massive. That is why the A wave goes like this, like a cannonball. By right, if this valve was open and the atrium contract, pressure will not accumulate. But now you're contracting in an enclosed space, nothing to absorb that pressure. When you finish, pick a bottle of Coke, plastic Coke, put it in your mouth and be drinking it normally. And when you drink it normally, try to draw out air from that Coke down to your lungs. You will definitely see how pressure will accumulate in your jaw. You'll be forced to throw it away. That is because you're doing it in an enclosed space. That is what causes that Canon A wave to go up. Of course, we've definitely settled that of AFib. Now, when you look at your C wave, we've settled everything about C wave. When you talk about your X descent is when that pressure is dropping progressively in the atrium. Now, I want to let you know if somebody has um, regurgitation, this will not definitely be there. In a patient with regurgitation, you're not going to see the X descent. The question is, why is that so? Think about it. Let's illustrate that again. Now, in a patient that has regurgitation, this is what happens, Tchaikovsky regurgitation. Now, when you're having that X descent, normally the Tchaikovsky valve is supposed to be closed. The ventricle is supposed to be contracting and taking their blood away, and the atrium is supposed to be relaxing. But now look at what happened. If this valve is regurgitant, as this ventricle is trying to contract, all these things are blood. By right, that valve is supposed to be slammed shut. But because it is regurgitant, as this ventricle is trying to contract, it will push blood back to the atrium. And remember, volume and pressure is directly proportional. So this blood that is pushed back to the atrium will definitely raise the atrial pressure. So that is why you cannot see the X descent in a patient that has Tchaikovsky regurgitation, because at every point in time, blood will be entering the atrium. Now, that time when the atrium is supposed to be relaxing and you have the X descent is when your ventricle will now be regurgitating blood back into it, and you will now lose your S descent. Now, if we choose to move on, if you look at your V wave, we've definitely settled the V wave. Your Y descent is going to be absent in cardiac tamponade. That is because of equalization of pressure. In a patient that have cardiac tamponade, this is what happens. The pressure in the four chambers most times become equal. Now, imagine something. If the pressure in the atrium and the pressure in the ventricle becomes the same, the atrium cannot empty its blood into the ventricle. That is the truth. If this pressure now, let's assume you have 20 here, you have 20 here, that valve will not open. Two of us are equal. Everybody hold your own. You can only have that valve opening when the ventricular pressure falls below the atrial pressure. But now there's equalization of pressure. And if the valve does not open, automatically you cannot have that Y descent, because that Y descent is the passive feeling. You don't have that pressure gradient to definitely cause it to happen. In restrictive pericarditis, you can definitely see it being prominent. That is because of the constrictive nature of that pericardium. I will definitely tie in that concept in depth in the pathology. which unfortunately I will not get to do with the general house. Now, this is definitely the jugular venous tracing in those different conditions. Now, the next thing we're going to look at is what we've already talked about those ones above. The next thing we'll look at is what they call the pressure, volume, and valvular diseases. That's lobes we did. Remember, we have done these two things, we have settled it. We have settled this one to definitely be the pressure volume tracing, and this one is definitely the pressure time tracing. These are two things we already settled. Now, if that is understood, let us still push on to look at some things that are very important. We're going to talk about some things that are very important. Now, let us apply some of these concepts into diseases. Let us look at how we can apply these concepts in specific disease patterns, specific disease presentation. Now, let us start with the first one, which is aortic stenosis. Use the information you have. Learn how to play with your information. The information is for you to play with it. Play with it until it makes sense. Now, the first question I want to ask you is this. What is afterload? We said afterload is definitely the pressure the heart needs to overcome before it pushes out blood from the ventricles. Now, that pressure is related to the pressure in the aorta. If the aorta becomes stenosed, it simply means that the pressure will definitely go up. Now, just imagine a woman that is obese. Just imagine a fat woman that is obese. She wants to enter the house and you open the door widely. That woman will enter without any stress. Now, let's imagine now you now open the door very small and you tell her to squeeze herself through that small space. That woman is definitely going to exert a lot of energy before she can pass through that narrow space. That is exactly what the stenosis is. Once the vessels narrow, the heart now has a lot of responsibility to be able to force the blood through that narrow space. So it has a lot of work to do. Now, see how you can put this into tracing. Look at this classically. You can see that the black line is always the normal. Now, look at this particular red line. This is definitely the one that is telling you the aortic stenosis. Look at the ventricular pressure. The ventricular pressure has gone up a lot. Now, the reason the ventricular pressure went up is that the ventricle has to do a lot of job to push the blood through that narrow aorta. That is why you see this pressure rising to this point. Let me optimize my screen a little. Look at the pressure rising to this point. Now, this is also the pressure time tracing. Remember, this line on top, we settled it. This was the ventricular pressure. The red line is also the atrial pressure. Look at how it is in a normal person. In a normal curve, this is how it is. The ventricular pressure is just slightly above the aortic pressure. Look at it. Very slightly, almost insignificant. Look at the distance between two of them, very insignificant. Now look at a person with aortic stenosis. You see the ventricular pressure rises far above the aortic pressure. Look at the difference between the two of them. Look at the gap. Unlike in the normal where the gap is almost non-existent. Once you see that, what you're dealing with is definitely aortic stenosis. Once you see any curve that the pressure goes up markedly, far more than the aortic pressure, please, what you're dealing with at that point in time is definitely your aortic stenosis. We have settled a whole lot of things already. There's a lot of things we have already talked about, which we're not going to re-talk about again. We've settled them already. Now, we have talked about the fact that when you have increase afterload. You will definitely have a drop in your stroke volume. For your stroke volume to drop, it simply means your end systolic volume will increase. I don't want you to get confused. Think of what we have talked about, and it should be making sense already in your head. Just think about it. It should be making sense in your head. Now, look at it in this dimension. Look at it in this dimension. Now, we definitely settled it that let's assume, let's choose a practical example. You have 1,000 mils of blood as your end diastolic volume. Now, pressure went up, and out of that 1,000 mils of blood, okay, no, let's use the normal example we have been using. Then we can tie it down to this and it should make sense. Now, in our normal example, we said the end diastolic volume is 1,000. Let's do it at the level of the whiteboard. I like the whiteboard a whole lot. Now, we said the end diastolic volume in a normal person is 1,000. The blood that returned in the heart was 1,000. Now, let's assume this person's heart is normal. The pressure is normal. If this person is able to pump out 900 mils of this blood, you're able to take out 900 mils of this blood, what do you think will be left? It's only 100 that will be left. Now, let us look at this person now that has gotten aortic stenosis. The person still received 1,000 mils of blood coming back to his heart. Now, the person's pressure in the aorta has risen maximally. So the person is not able to move out all the blood because pressure has gone up. I explained this yesterday by using boxes, for example. Now, you are an adult. If I give you 20 boxes that is weighing 5 kg, and I tell you, please, you have 30 minutes. Can you pack it from this room to the other room? You can comfortably do that job, even in less than 30 minutes. But if I increase the weight of those boxes to like 50 kg, there's a possibility that you can only pack like 5 in 20 minutes. That's if you're even strong enough. So the higher the pressure, the less you can take out. So now the pressure has gone up, and this heart is only able to take out 500, for example. The other 500 is definitely left. What is left in the heart at the end of the day is what is called the end systolic volume. So you can see that the end systolic volume has increased in this patient with aortic stenosis compared to what you have in a normal person that is 100. But the stroke volume has fallen compared to what you have in a normal person that is 900. That is all what they were trying to illustrate here when they say there's increased left ventricular pressure in response to that aortic stenosis. End systolic volume goes up, no change in end diastolic volume, but the stroke volume will drop. Of course, the patient will have ventricular hypertrophy. You know why the ventricle should hypertrophy, to definitely reduce the wall stress. Now, what I want you to understand is this. If you look at a particular graph and you cannot see the isovolumetric relaxation or the isovolumetric contraction, that graph you're dealing with is definitely a graph of regurgitation. That is the first thing you need to know. If you see a graph, I repeat, if you see a graph and that graph does not have isovolumetric contraction or isovolumetric relaxation, what you're definitely dealing with is definitely a regurgitation. Now, let us try to see if we can put meanings into that. Let's see if we can find a way to insert meaning into the things I have said, if it will make sense. Now, trying to put meanings into what I have said. Now, let's definitely do it at the level of the whiteboard. I'll definitely draw the concepts at the level of the whiteboard, and We'll definitely have to look at it and see how it will make sense. Now, but before then, I just want you to imagine this. You just need to imagine it. Now, coming to the whiteboard here, coming to the whiteboard here. Now, let us assume this is the normal tracing. Let me trace it first. This is the normal tracing. This is isovolumetric relaxation. This is ventricular filling, isovolumetric contraction. This is ventricular emptying. This is how the normal curve is. Now, see what I want you to understand. Just imagine this patient have aortic regurgitation. Where does the aortic valve close? This is where aortic valve close. Now, if the patient have aortic regurgitation, it simply means that the aortic valve is incompetent. That is what it simply means. The aortic valve is incompetent. Now, because the aortic valve is incompetent, when the aortic valve is supposed to close, it will not close. Blood will be leaking from the aortic valve back to the ventricle. So if blood is leaking from the aorta back to the ventricle, you will not have this isovolumetric relaxation because volume is coming in. On the other hand, imagine if you have mitral regurgitation. This is where your mitral valve is supposed to close at this point. Now, imagine that the mitral valve failed to close. At this point, you're supposed to be having isovolumetric contraction. You will definitely have blood leaking back because the mitral valve did not close. So automatically, you cannot get that isovolumetric region. Isovolumetric is that there will be no change in volume. But because of the incompetent valve, of course, blood will always be leaking back and forth. That is why when you look at these two graphs, look at that of aortic regurg, look at that of mitral regurg. The black is the normal. You can classically see that the black has the isovolumetric on both sides. But look at the green in mitral regurg. You cannot demonstrate isovolumetric relaxation or contraction. The same thing as this red in aortic regurg. Look at the red in aortic stenosis. You can classically see the isovolumetric relaxation and isovolumetric contraction. That straight line. So when you see a graph, you cannot pick out that straight line. First thing you need to tell yourself is, this is definitely a regurgitant graph. Look at your answer choices. If there's only one regurgitation, pick it and move on. You don't need to spend energy. You don't need to stress. The only place you now start stressing is when you now have more than one of the regurg. You now have your aortic regurg. You now have your mitral regurg. You will now need to sort it out. Now, let us look at the pressure time tracing of aortic regurg. That is the next thing now we're going to talk about. So let us draw our tracing again. No, let me bring the normal and bring the abnormal. Let me bring the normal, then we compare it with the aortic regurg and see how it will make sense. This is the normal. So this is the normal. Goes up. Now look at where the aortic pressure starts. It starts at 80 and gets to 120. This is 80. This place here is 80. Now look at the other one. This is the aortic regurg. This is the aortic regurg. Now look at something. No, let the size be the same before your mind will start going to stenosis. Let the size be the same. Now look at something. Look at where the aortic pressure starts from. The aortic pressure starts from below 50. This is below 50. You can classically see that it is far below that of the normal. So instead of the aortic pressure starting from 80, it is starting from 50. Now the question is, why is that supposed to be so? Now see what I need you to understand. Volume and pressure go hand in hand. Think about it. If I give you a 20 liters of fluid, I think my router is really going bad. I hope I'm still in this meeting. Yes, I think I am. Let me just give you this illustration. Imagine I give you 20 liters of fluid for you to carry on your head, and I now reduce that fluid to like 10 liters. Which one do you think will have more pressure on your head? It is when you were carrying the 20 liters of fluid. The more the volume, the higher the pressure. That is like a norm. So think about it. In aortic regurgitation, let's say this is the aorta. Let's say this is the aorta. Now, in aortic regurgitation, the aorta is losing the blood it's supposed to have. It is sending it back to the ventricle because the valve cannot close. Let's assume the atrium is supposed to hold, sorry, the aorta is supposed to hold like 1,000 mils of blood, for example. Now, at the end of this systole, this valve is supposed to close and it holds this 1,000 mils of blood. But because it is regurgitant, you have this valve leaking. Because this valve is leaking, let's say 200 mils of blood will definitely leak out. And at the end of the day, you now have 800 mils of blood. 800 will not give you the same pressure as 1,000. So the pressure drops. Classically, that is just how you pick it out. So look at all the graphs. Look at all the graphs. Look at it closely. Look at it in your own book. You can classically see that for all the graphs, you can see that the pressure of the aorta started above 50, except for your aortic regurgitation. Please, when we mean start, it is that point where the red line kissed the blue line. It is not this tail here. Look at where they kissed each other. The red line and the blue line, where they intersected, is above 50. Classically, that should be 80. Now look at this one of aortic regurg. See where the red line intersected the blue line. It is classically below 50. Even a blind man can appreciate that. Look at every other. Every other will be above 50. Once you see a pressure time graph that the aortic pressure started below 50, it is classic for aortic regurg. There's no two ways about it. There is just no two ways about it. It is specific. You pick your answer, you move on. Now, if you look at the various manipulations you can do, I'm not going to spend so much energies on these manipulations because I've talked about this manipulation at length. So I'm guessing we should definitely be conversant with these manipulations at this point. We've talked about it already at length. Now, if you look at the manipulations in aortic regurgitation, end-diastolic volume should increase. End-diastolic volume is the volume of blood held in the ventricle at the end of diastole. Now, the ventricle is receiving blood from two different sources. It is receiving blood, backflow of blood from the aorta. It is also receiving blood from the atrium. Think about it now. If it is getting blood from these two sources, automatically, you will definitely have the end-diastolic volume going up. Now, once your end-diastolic volume goes up, the heart is garbage in, garbage out. The systolic volume will go up. Like I've said, you will never have that isovolumetric contraction and isovolumetric relaxation. Now, let us tie in the mitral stenosis. When we tie in the mitral stenosis, in mitral stenosis, what you need to understand is this. This is the atrium. This is the ventricle. The problem in mitral stenosis is not the ventricle. The problem in mitral stenosis is with the atrium and the mitral valve. Those are where the problem occurs. Now, look at what you need to understand, and this is what you need to know, and this is where it needs to make sense. Now, on a normal day, when the atrium wants to empty its blood, the mitral valve is supposed to open easily, and the atrium empties its blood. But in this patient now, this is the problem. The mitral valve will become calcified, meaning it will fail to open normally. The atrium, we need to force it open, like you need to exert a lot of pressure to force it open before the atrium can empty its blood. What it simply means is that the atrium, we need a lot of pressure to force this valve open. Just imagine your door. The door to your house becomes stiff and rusty. Normally, you're just supposed to open your door and push it with little or no pressure, and it opens. But imagine the door becomes stiffy, the door becomes rusty. You open it, you need to use a lot of energy to definitely push it open. That is exactly what is happening here. So the atrial pressure goes up. The atrial pressure becomes markedly increased. That is the problem this patient is having. Now, if you look at them, the main challenge or how to pick them in a graph is that the atrial pressure is constantly high. Look at the atrial pressure is this one always at the bottom. This one at the bottom here, we settled it. Now look at the atrial pressure, whether it is diastole or whether it is systole, the atrial pressure will always be very high because the atrium has acquired a very high pressure that is enabling it to open up that stenosed mitral valve. So if you see a graph that the atrial pressure is constantly high, that is a graph of mitral stenosis. Of course, if you look at mitral stenosis, the end diastolic volume will reduce. Why would the end diastolic volume reduce? The mitral valve cannot open so that the atrium empties to the ventricle. If the atrium cannot empty completely to the ventricle, automatically, it simply means that your preload or the blood that come back to the ventricle, which is the end diastolic volume, will definitely drop. If your end diastolic volume drops, automatically you're going to get a reduction in your stroke volume. And the body will try to compensate by trying to maximize the stroke volume, even though the stroke volume is low. That maximization is what will reduce the end systolic volume. So all of them goes down. The final thing is your mitral regurg. Mitral regurg is when you definitely have incompetence of the mitral valve. So when you're supposed to have your isovolumetric contraction, blood will definitely be moving. Blood will definitely be moving back into the atrium. Now, if you look at them, mitral stenosis and mitral regurg has a little similarity. Now, what is their similarity? Their similarity is that the atrial pressure will rise. If you're very observant, you will see that the atrial pressure rises. But what you need to know is that the atrial pressure rises at different times. I want you to observe that. Now, the atrial pressure rises for your mitral stenosis in both systole and in diastole. If you look at it with an observing eyes, you see that both in systole and in diastole, this atrial pressure is constantly high. But if it's in mitral regurg, the atrial pressure only rises during systole and it falls in diastole. Look at it. This is where your systole starts when your aortic valve open. You see that the atrial pressure starts rising. Because at that point in time, you have backflow of blood coming from the ventricle back to the atrium. That is why you cannot have that your X descent, because the pressure will keep rising in the atrium. That is why the pressure is rising, because you have blood moving from the ventricle down to the atrium. Automatically, if you look at this, you will definitely have a reduction in your end systolic volume, because a lot of blood will definitely leave the ventricles. There's forward movement and backward movement. Backward movement means that blood is going into the atrium. Forward movement means that blood is going into the aorta. So that will definitely decrease the amount of blood left at the end of systole. So end systolic volume goes down. Now the atrium is getting more blood, both blood from the regurgitation of the ventricle and blood from venous return. So it is getting more blood than before. And it is going to empty all those blood into the ventricle. So automatically, you're definitely going to have increase in end diastolic volume. Of course, stroke volume will go up. When we get to pathology, I will tie in the tricky concept of stroke volume in mitral regurg. If you get a stroke volume of 600 mils in a patient that have mitral regurg, you need to be very careful, because stroke volume is only looking at, what stroke volume is looking at is, stroke volume is looking at the fact that what is the amount of blood that is leaving the heart. It is not looking at whether that blood is going forward or backward. So if I have a stroke volume of, let me say, 600 mils, it is possible that it's only 300 that's going to the aorta. The other 300 is going back to the atrium. Now, let us do the splitting quickly. I just have a few minutes to do the splitting. Probably I should be able to tie the splitting in 10 minutes. I don't think I want to spend more than 10 minutes, so that we can definitely close at exactly 7 p.m. EST. Now, this is what I need you to understand. There's what we call physiologic splitting. Remember, I told you the closing of the heart valves is what is responsible for causing your heart sounds. Your tricuspid valve and your mitral valve closing definitely causes your S1. Your pulmonic valve and your aortic valve closing definitely causes your S2. But this is what I want you to understand. Now, during inspiration, when you're breathing in, there is splitting of the S2. It is called physiologic splitting. I like asking a lot of why. I don't just want to understand it at that level. It will be cramming. I want to know, why will there be splitting when I am breathing in? Now, let's assume, let's look at this, for example. Let's say this is the right part of the heart. This is the left path. Now, the right path is moving their blood. The left part, rather, is moving their blood to the aorta. The right part is moving their blood to the pulmonary artery. Now, let's assume both of them is definitely getting fairly same amount of blood. Let's say 600, 600. If two of them are getting, let's say, 600 mils of blood, we expect that they should push out their blood at the same time. The valve should close at the same time. That is what should happen normally. That is what happens in expiration when you're breathing out. But when you're drawing in breath during inspiration, there is decrease in the intrathoracic pressure. Once you're drawing breath inside, you have increased venous return to the right side of the heart. When the pressure drops, it causes more blood to be returned to the right side of the heart. So when you're breathing in, the blood that comes to the right side of the heart will move from 600 to about 800. It moves to about 800. Now, if you think about it, it will take 800 a little longer time to go through the vessel than 600. That is the reason why you will have that physiologic splitting of the S2. So you're going to hear the pulmonic valve first. Then, sorry, you're going to hear the aortic valve first because the aortic valve is the left side of the heart. So the aortic valve, we empty E600, the left ventricle rather, we empty E600 first into the aorta. So the aortic valve we close first. So you hear the aortic valve closure first. Now, it will take the right ventricle a little more time to empty is 800 because 800 is bigger than 600. So you will hear the pulmonic valve closing a little bit later after the closure of the aortic valve. That is what is called the physiologic splitting of the S2. That is all what we're trying to illustrate it here for you. It happened during inspiration. You're not going to see it in expiration. You can see that the B2 is closing a little bit late than the A2. This is normal. You shouldn't be bothered. But now there's what we call wide splitting. Wide splitting of the second heart sound. Now, in wide splitting, naturally we understand though that during inspiration, you're definitely going to get some form of physiologic splitting. That one we know. But now, when this splitting increases beyond normal, that is when we start getting worried. That is where the concept of the wide splitting comes in. That one is no longer physiology. It is now pathologic. Now, how do we know and how do we handle that? Now, let us look at this other concept. Imagine that you brought in 800 ml of blood to the right side of the heart at the end of inspiration, and you brought 600 mils to the left side. Automatically, I'm expecting my physiologic split to happen. But now let's assume that in this person now have pulmonary artery stenosis. Look at this pulmonary artery. It is now reduced. The lumen is now reduced compared to that of a normal person. Now, what it simply means is that you will even need a longer time for you to pass this 800 ml of blood through this narrow pulmonary artery. Of course, it simply means that that splitting will definitely get longer. If it will take the right side of the heart about 1 more seconds to be able to push in that blood in a normal setting, it will take them like 4 seconds. You find out that that splitting becomes more delayed. It becomes widened. So when you see that splitting getting wider than normal, it is definitely the wide splitting. It simply means that there is a problem on the right side of the heart that is preventing the right side of the heart delivering that blood to the pulmonary artery. Pulmonary stenosis is the most common cause. It could definitely be a right branch bundle block, which prevents contractility of the right side of the heart. If the right side cannot contract, it will take them a long time to push out blood. Now, there's what they call the fixed splitting. Now, what does the fixed splitting means? The fixed splitting means you keep hearing that splitting both on expiration and inspiration. By right, you're supposed to hear this splitting only when you breathe in, whether it is the wide splitting or whether it is the normal physiologic splitting. They usually happen on inspiration when you have more blood going to the right side. But when you talk about the fixed splitting, in the fixed splitting, you keep hearing this particular heart sound. Under any condition, you just keep hearing it. Now, a lot of people used to cram this thing Whenever you hear fixed splitting of A2, it is ASD. When I started, I also crammed it. When I'm doing MBME question that time, in fact, where I did my USMLE, that was the norm. Um, what we read from FA. As we read this thing from FA, I had some friends, definitely we do discussion with. So we just settled it out. Oh, whenever you see fixed splitting in MBME, it is definitely um, atrial septal defect, ASD. But what you need to understand is this. Yes, you can cram a lot of things and you may get lucky sometimes. But if they decide to test the depth of your understanding, you will definitely know that there's problem. So you need to understand why things happen the way they happen. So that no matter how the twist come, you will definitely be able to pick out what the problem is. If you must do this exam, I would definitely advise you definitely do an MBME, an online MBME, and test your skills. Test the amount of information you have. Now look at what causes that fixed splitting. This is your atrium. This is your atrium, left and right. These are your ventricles, right and left. So this is the right, this is the left. Now, when a patient have an ASD, atrial septal defect, the question is, atrial septal defect, what kind of shunt is it? In a normal person, if Eisenmenger syndrome has not happened, ASD is a left to right shunt, meaning blood will leave the left side of the atrium where the pressure is high and go to the right side of the atrium where the pressure is lower. This is what you see in normal ASD. This is how it happens. Now, so this is what happens. If blood is leaving the left side and coming to the right side, it simply means that at every point in time, the volume in the right side will definitely be higher than the volume on the left side. Let's assume two of them receive, the right atrium got 1,000 mils of blood initially. The left got 1,000 mils of blood. Two of them are equal. But now, the left now push extra 300 to the right, making the right now 1,003 and the left dropping to 700. This does not require inspiration to happen. As long as that hole is patent, whether it is breathing in or breathing out, it will be happening consistently. So what it simply means is that at every point in time, the right side of the heart will have a higher amount of blood than the left side. That is why the splitting is fixed. Whether it is in inspiration, you will hear it. Whether it is in expiration, you will hear it. Reason being that the right must always have a higher amount of blood because of that shunting from the left to the right. Finally, the last one, and this is where we run, is the paradoxical splitting. Now, the paradoxical splitting is definitely when you have that splitting reversing. It is now your P2 closing before your A2, meaning your pulmonic valve is closing before your aortic valve. For example, if this person have aortic stenosis, even though you like, put more blood in, let more blood be returned to the right side during inspiration, but because of that stenosis of the aorta, it will take the left side a longer time to empty its blood compared to the right. So under that condition, the splitting will switch from hearing an A2 first to hearing a P2 last, to rather hearing a P2 first and hearing the A2 last. That is what is called the paradoxical splitting. And where do you get to see the paradoxical splitting? I've already talked of aortic stenosis. You can also see it in left bundle branch block, when the left ventricle is not able to contract well and put out its blood into the aorta. Now, this is definitely where I'll be coming to the end of this section. I've been able to take my time and exhaustively talk about these 3 pages. I talked about these 3 pages in almost 2 hours because it is the most highly concept in cardiophysiology. When we come to the next section, I will definitely tie in the concept of making diagnosis of cardiac questions when they mistakenly give you the heart sound or the murmur the patient have. If you do my classes, you can never fail a question that they put the location of the murmur. It is unforgivable. We're going to sort that in the last section. So I will stop recording this class at this point. Please, if your question is for me to go through the entire stuff